and take over the stage. Thank you.
Speaker from Temple Health System in Philadelphia, presenting on classic Hodgkin lymphoma, EBV positive, following immunomodulatory IL-23 inhibitor therapy. Dr. Shaw.
Good morning, everyone. Thank you, panelists. Thank you, panelists, for choosing our case for the presentation. Without further ado, to jumpstart this morning, I'll be discussing an interesting case of EBV positive classic Hodgkin lymphoma developed in a patient receiving IL-23 inhibitor therapy for psoriasis and its tumor microenvironment study. I do not have any relevant disclosure. In December 2022, 40-year-old male with a 10-year history of psoriasis started receiving IL-23 inhibitor therapy for psoriatic arthritis. 3 to 4 months after, in March 2023, patient started experiencing progressive symptoms, including night sweats and syncope episodes. In July 23, which is 6 months after initiation of therapy, patient noticed a painless lump in the right cervical region, which on CT scan showed bulky right cervical lymphadenopathy with largest node measuring 3.9 centimeter. On subsequent PET scan showed hypermetabolic lymph node conglomerate with 8.8 centimeter in greatest dimension and high SCV of 18.8. Excisional biopsy showed a partially preserved architecture and scattered HRS cell, predominantly in the interfollicular region. IC showed a characteristic phenotype of Hodgkin lymphoma, showing weak to moderate PAX5 expression, strong MUM1, along with membranous and Golgi pattern CD30. Additionally, CD20 and CD19 showed a subset of HRS cell with weak expression, while CD200 demonstrated moderate to strong expression of HRS cell as suggested in the study. Most importantly, HRS cells are positive for EBER by in situ and showed strong expression of LMP1, while negative for EBNA2, indicating ABV latency pattern 2A. Chromosomal microarray analysis did not detect any genomic imbalances, while NGS detected tier 2 splice site variant in ATR gene with allele frequency of 57%, presumably of germline in origin. No other significant changes were found, as discussed by previous presenter yesterday, possibly due to limitation of method from low percentage of neoplastic HRS cell. So our proposed diagnosis is classic Hodgkin lymphoma, EBV positive, possibly iatrogenic, or related to IL-23 inhibitor therapy. Panel agreed with the diagnosis and posed following question to describe possible pathogenetic link between treatment of psoriasis and development of classic Hodgkin lymphoma, and current evidence of IL-17 and 23 inhibitor therapy associated secondary malignancy. Before we go further, we can brief review pathogenesis of psoriasis, in which there is predominantly TS17 pathway hyperactivation via IL-23 and IL-17 axis due to release of TNF alpha and interleukin 23 from activated dendritic cell. IL-23 is a key cytokine for this pathway, which acts on IL-23 receptor complex, leading to JAK2 STAT3 phosphorylation and produce interleukin 17 along with interleukin 22. Interleukin 17 being the central effector responsible for the Th17 cell expansion to develop autoimmunity, and it also gives protection against some viruses. As you can see, anti-IL-23 inhibitor agent act on P19, a unique subunit of interleukin 23, while combined inhibitor IL-12 and 23 act on P40, which is a shared subunit between IL-12 and IL-23. And IL-17 acts downstream to IL-23, IL-17, and acts on IL-17 as well as its receptor. to describe literature review, the largest study from 2006, which involves 160,000 patients, established psoriasis as an independent risk factor for lymphoma, in particular, classic Hodgkin lymphoma and cutaneous T-cell lymphoma. So far, only one case of Hodgkin lymphoma reported in 2020 in a patient receiving combined IL-23 and 12 inhibitor therapy. Most recent meta-analysis and systematic review involving approximately 6,000 patients reported no increase in pooled relative risk of malignancy in patients receiving these inhibitors. And lastly, most recent international population study, which involved approximately 16,000 patients, showed overall decreased risk of lymphoma, with caveat being that overall decreased risk was in comparison to the patient receiving TNF-alpha inhibitor. So as we see, it's overall decreased risk with these inhibitors. It is important to note that microenvironment of EBV Hodgkin shows usually Th1 profile, while EBV negative lymphoma shows Th17 profile. This is mainly due to plasticity and diverse polarization of T helper cells in these two subgroups. Based on the review of literature, we hypothesize that a blockade of IL-23 and 17 leads to possible loss of protective antiviral effect, leading to emergence of EBV positive or EBV-driven classic Hodgkin lymphoma. Soon after the diagnosis, IL-23 was discontinued, and 2 to 3 weeks after, patient received 2 cycles of ABVD regimen, mainly due to large size of the mass and repeated syncope episodes, and patient showed complete response. To understand the immunomodulatory effect of interleukin-23 inhibitor, we studied tumor microenvironment of this case using COMET platform, in which sequential immunofluorescence uses multiple marker up to 50, in which we use up to 11 markers. For each marker, there was sequential short incubation with primary antibody followed by fluorophore tag secondary antibody to end the cycle with elution step. And after each cycle, you capture image, and cycle was repeated to render final composite of all the monochromatic images from each marker. Out of 11 markers, we chose CD8 and interleukin-23 receptor are still pending validation. I'm going to share preliminary finding of this study. But from the remaining 9 markers, we use T-box transcription factor, which is TBET, to identify Th1 cells, CCR6 to identify Th17 cell, which is fairly specific for this lineage, while CCR4 for both Th2 and Th17 cell. We'll review results of each marker. As you can see, CD4 shows predominance of CD4 positive T cells in yellow, with rare TBET co-expression, which confirms that Th1 cells are few. As you can see in the previous image, there were red color nuclear positivity. Those were mainly present in HRS cell, in addition to membranous dim co-expression of CD20 in those HRS cell, while TBET positive T cells are rare. These findings were validated by ISC as well. CCR6 in green, a marker of CS17 pathway, shows co-expression with CD20 B cell, while CCR6 positive TS17 T cells are rare. This finding is additionally confirmed by TS17 marker, which is interleukin-23 receptor. ISC shows paucity of TS17 cell. CCR4 in blue color, which is a marker for both TH2 as well as TS17, does not co-express with CCR6, which is marker for TS17, indicating dominance of TS2 cells. This finding is additionally confirmed by ISC, showing dominance of the same finding. CD163 in magenta color shows relative lack of M2 suppressor macrophages, while immune checkpoint CTLF4 in purple color shows numerous immunosuppressive regulatory T cells. This is final composite of all 9 markers. To summarize, we have paucity of Th1 cells shown by few TBET positive Th1 cell, indicating possible loss of protective anti-tumor effect, while paucity of Th17 cell shown by scattered CCR6 positive, CCR6 only positive T cell, indicating loss of immunoprotective effect against virus. And there is predominance of Th2 cell, indicating possible reprogramming of Th17 cells towards Th2. And this Th2 profile is actually different from expected Th1 profile as described previously in the literature in EBV-positive classic Hodgkin lymphoma. We believe it's likely attributed to anti-IL-23 therapy. In conclusion, therapy of psoriasis with IL-23 inhibitor has most likely promoted reprogramming of immune system from Th17 to Th2 response, permitting the development of EBV-driven classic Hodgkin lymphoma. With that, I would like to acknowledge my mentor, Dr. Nejad and Dr. Vasik, and the rest of the team. Thank you.
Okay, we have time for a question or two. Yes. Oh. Sorry, let's take one in the back first, and then Dr. Jaffe.
Hi, good presentation. I'm curious, do you think just cessation of IL-23 therapy would have caused any regression in the lymph nodes? So do you think that this patient needed chemotherapy?
Yeah, we thought about it, but patient had syncope episodes and also large mass, so we couldn't wait more than 2 to 3 weeks after. But that was initially our consideration. And also Hodgkin lymphoma, drawing analogy from post-transplant cases of Hodgkin lymphoma, clinical team thought they'd behave aggressively, so it is important to initiate therapy rather than waiting based on the withdrawal of IL-23 inhibitor response.
And are there any other cases where, patients with this kind of therapy have had, say, smaller volume lymphadenopathy which has regressed following cessation of the drug?
Sorry, I didn't get your question.
So are there any other patients in the literature who have had developed smaller volume lymphadenopathy with this kind of therapy where cessation of the drug led to regression of those lymph nodes?
So literature is very scarce. So far, only one case of Hodgkin lymphoma reported with combined IL-12 and IL-23 inhibitor. In that case, also patient presented in 2 to 3 months after the initiation of therapy. So we do not have any regression evidence, but we do know that there is one case reported with the similar presentation. That was actually earlier than this 2 months, while we have up to 6 months.
Thank you.
Dr. Jaffe.
Yes. Your case is somewhat reminiscent of the Hodgkin-like lesions that are described with methotrexate. I wonder if you looked at EBV viral load, since in Hodgkin's the EBV viral load is usually low.
That's right.
Yeah.
So the patient was not known to have EBV status at the time, but we did after that. It was 79 copies.
So it was low.
It was low, yes. And it is most recent follow-up did not detect any viral load somehow.
Okay, thank you. We're going to have to move on, so we'll table the other questions for the coffee break. Thank you, Dr. Shah.